Hi, everyone. My name is Jeremy, and I am a representative of EHN Canada. We are a nationwide network of treatment centers for addiction, trauma, and mental health. We have facilities located in Nanaimo, British Columbia, Calgary, Alberta, Toronto and Peterborough, Ontario, Montreal, Quebec, and Annapolis County, Nova Scotia. We offer high quality inpatient, outpatient, and online treatment programs. For more information, please visit our website at ehncanada.com. Just in terms of housekeeping, everyone is on mute and cameras are off for today's webinar, but please feel free to use the Q&A box located at the bottom of your screen to submit questions for our speaker. We will try to get to as many questions as we can at the end of today's session. Today's webinar is in fact being recorded, and we will be sending out a follow-up email next week that will include the link to today's videos, the slides, and any other useful resources mentioned, as well as your CEU certificate. Again, just a reminder, we will be sending out an email sometime mid to late next week with a copy of your CEU certificate. We appreciate your patience. I am located in Toronto. Toronto is located on the traditional territory of several nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. It is covered by Treaty 13 with the Mississauga of the Credit. We also have presence in today's webinar located at our Edgewood facility in Nanaimo, British Columbia. They are on the traditional and unceded territory of the Coast Salish peoples, the traditional territory of the Sumimuuk First Nation. Vancouver is on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. If you're new to this work and want to find out whose land you're on or grew up on, please check out www.native-land.ca. Many more of you may be physically present elsewhere. I encourage everyone to use the chat function to, where applicable, share whose land you are on. Now, to get to today's session, we have the lovely Ryan Slobodian back for another session. Ryan has worked in mental health and addictions for the past 7 years. While counseling vulnerable homeless youth and young adults in Calgary, he saw firsthand how addiction and trauma interact and the immense impact it has on people. Working with these survivors, Ryan developed a passion for treatment in this field. He obtained his Bachelor of Arts in Psychology through the University of Calgary and earned a Master of Counseling degree from the City University of Seattle, and also engaged in original research of belongingness and stigma reduction during this time. Ryan is certified in eye movement desensitization and reprocessing therapy and accelerated resolution therapy for the treatment of psychological trauma. He is currently a registered clinical counselor with the British Columbia Association of Clinical Counsellors and a member of the International Institute of Trauma and Addiction Professionals, where he is in the process of becoming a certified sex addiction therapist. Please help me welcome Ryan.
Hello, everyone. Always nice to be doing these webinars. Always a privilege and an honor. I love talking about this kind of stuff. It's a passion of mine. So I appreciate everyone showing up, and I'm excited to get talking about this. It's work we do every day in our CTAP and TPIP program here at Edgewood and Nanaimo, and I'm very passionate about sharing it with you all. So I'm going to share my screen here. Okay. So today we're going to be talking about dysregulation and stress responses. That can be, especially with a lot of literature out there, it can be quite, I think, confusing in terms of terminology. So I'm going to go over that a bit. I'm going to go over a little bit of neuroscience that's involved with this, and then some strategies as to how to help with dysregulation and managing stress responses in the context of PTSD and complex trauma. Okay, so let's get started. So how does dysregulation happen? So we need a couple things to happen for somebody to become consistently dysregulated. So at its core, trauma shatters somebody's illusion of predictability and control and safety in the world. A lot of people can approach the world maybe with like rose-colored glasses. They and feel more safe approaching the world, more curious. But when trauma has happened, that has been unpredictable, extreme, prolonged. There is sensitization and vulnerability. So timing, nature, pattern, and intensity are all very important factors when assessing severity of dysregulation and trauma. We also see that predictable, moderate stress can actually be resiliency building. So like take this webinar, for example, for me. I mean, there's a moderate amount of stress that goes into this. I have to prepare for it. I have to speak in front of people, which it elevates stress levels, but it's moderate and it's controllable. I know when it's going to be over. It can be resiliency building. For in the extreme end, where maybe somebody's grown up in an abusive household, when it's been very consistent, it's been very intense, and the timing has been in childhood, that can lead to a sensitized stress response, which basically a moderate stress response becomes a terror response. So take, for example, the military folks we work with. So if someone has done a few tours and they were home and they're out for dinner on a pleasant summer evening, and a car backfires, their brains are going to be interpreting that as a terror response. Even though logically they're seeing everybody manage, they're orienting, nothing seems to be wrong. That's still getting internalized as a terror response. There's people also, so kids growing up in dysfunctional homes, abusive homes, there's also an internal storm that can happen, which is a lot of times called emotional contagion. So if an internal storm of a parent, they're always angry, irritable, living in fear, the child internalizes that fear, and can be overly sensitized to fear. So I also like to comment on I'll use the word resiliency a lot. When we speak about resiliency and trauma, we're not speaking of a traumatic event happened and now the person's fine. We're actually talking about, there's still always residuals. So Dr. Bruce Perry, which is a lot of what I follow in this webinar, he talks about it being malleable versus resilient. So, if you press on foam, it's always going to kind of come back to the exact same form. Whereas if you bend metal, there's always going to be slight abnormalities to it, because it's malleable. So we like to say that resiliency is like that. There's always going to be factors that residuals that happen. So I think that's an important piece to recognize. So how does this really happen? I like to look at Dr. Perry's neurosequential model. It's really digestible. I really like it. I use it a lot here in the trauma program to help our clients understand how their brain is reacting to certain triggers and stimuli. So basically how we interpret our world is through our senses. So senses from inside the body and senses from outside the body. So we use our 5 senses to incorporate everything we see in the world, and our brains are constantly matching it against previous experience. And the brainstem, so I'll work up, the brainstem is more involved in brainstem midbrain there. It's very primitive, right? It's the heart rate, blood pressure, sleep-wake cycles, hunger, thirst, motor control. As we go up, we get to the limbic system, which is a lot of emotional memory, emotions, attachment. And at the very top is the cortex, which is basically what makes us human. It's thinking, learning, all of the executive function, planning, assigning, which we'll get to in a bit, an autobiographical narrative, which is extremely important for somebody who's been through extensive trauma history, because a lot of that history is going to be fragmented. And we need to assign a narrative so it's easier to understand and make sense of. So the lower areas interpret and respond before thinking. This is a lot. So this is a lot of the issue that happens is when we've experienced trauma, or especially when we've experienced trauma as children. As kids, the cortex and these higher order areas of the brain, these neural networks, are not adequately developed yet. So all of this is kind of floating around these primitive areas of the brain, which are going to lead to implicit triggers, memories, which I'll get to in a second. We need, so basically, when we have no awareness, our sensory experience, we can interpret it, we can interpret triggers without even knowing it. So this could be hair color, smell, tone of voice, music, facial expressions. So our bodies and our emotions are responding to a stimulus, but we're not actually aware of what's going on, because we actually haven't worked up the brain yet to create meaning as to what's just happened. So this is where a lot of traditional therapeutic approaches can miss the mark a bit, because if we're incorporating experience up the brain, so through most primitive areas first, and then it travels to the cortex to make sense of and create meaning. We're actually kind of doing the opposite with a lot of talk therapy. We're starting at the cortex and trying to work our way down, but that's not how the brain works. We actually have to start at the very bottom. So that's why we're dealing with a lot of somatic sensations, emotions. We need to create awareness around that. And again, I'll get to that a bit later when I talk about how we address this. But the main point for this is really to understand that we don't think first. So that's a common misconception. We like to think we see a stimulus and we think about it first, but we actually are biologically wired to act and feel before we think, which is extremely important when you consider trauma treatment and really even any sort of treatment. This happens all the time in even relationship work. Oftentimes when if I see a couple, like, they're rarely talking cortex to cortex, they're talking limbic system, midbrain, brainstem to each other. And we have to get to that cortex level of discussion. But it's hard when we're triggered, because the cortex isn't fully available to us when we're triggered. That's the other issue. So the window of tolerance. So when we speak about being dysregulated, we are speaking about the window of tolerance. So this is where I actually like to look at language a bit too, because these states of arousal are going to mimic a lot of other language you might have heard. So hyperarousal, that's the hypervigilance, that's the panic, anxiety, anger, rage, right? Like, that's all a hyperarousal response. And we're going to need to downregulate when we're in that state. Other terms are sympathetic response. So when somebody's in a sympathetic response, they are hyper aroused. That's more of Stephen Porges' work, those are interchangeable. I like to say, just to lessen confusion. Hypoarousal, you might hear the term dorsal or parasympathetic. That's when we're despondent, shut down, we're numb, we freeze, there's passivity, just somebody who's presenting quite maybe like depressed. So I'd like to touch on that language piece a bit. So oftentimes what we're dealing with in trauma is a lot of behaviors that shift states, and it's dysfunctional. So when you think of somebody who is very detached and depressed, a great way to, well, not a great way actually, but an effective way is to get very angry at something. It activates the system, but it causes a whole lot of issues, obviously, and interpersonally. So we like to teach different skills, and I'll get to those later. I don't want to jump ahead of myself. The other thing around these arousal states is we can start to medicate them. So oftentimes, like for example, you can use uppers to get yourself up from a hypoaroused state. You can use opiates to numb, to bring yourself down when you're too hyperaroused. We see a lot of medicating other mental health issues and trauma. So like think of ADHD, for example. I can't even count how many people I've seen in treatment who are using cocaine to regulate themselves, because obviously it's an upper. It's very similar to what Ritalin would be. Obviously, it's not exactly the same, but whenever somebody's telling me, "Hey, I use cocaine to calm down and go to sleep," I'm referring them to psychiatry, right? So this is a very important piece around what we're trying to achieve. When somebody's dysregulated, we really want them in the window of tolerance. So they're alert, they're calm, they're open, they're flexible, they're not anxious or depressed. They're more open to connect to others, which we'll see is quite important. So the various stress responses, there used to be really in the literature, you'll often hear fight or flight, right? But what we know is there's a bit more to it than that. I'll go through fight or flight first. So this is a sympathetic response. So again, that would be when somebody's hyper aroused. That's usually, fight is when obviously it's in the name, somebody's might be aggressive. There's cues. So they're back to that neurosequential model. They're primitive areas of their brain. The cue is to fight. The cue to achieve safety is to fight their way out of it. We see this a lot with our guys in treatment who that's the only way they could get out of situations. If they're overseas doing tours and they're in like a firefight or something, you can't exactly just run from it. You have to fight. So when there's a loud noise or there's something that mimics that or mirrors it, their system automatically activates to fight their way out of it. Any sort of loud voice. I had a guy just in treatment. He just left. He did really well, and it could just be somebody raising their voice and totally fine. Just yelling at a friend, "Hey, I forgot that. Can you bring it to lecture for me?" And he would just get activated, like something's happening. I'm ready to go. I'm wired for sound. So it's also about understanding what is in the past that is currently affecting current reality. That's really important to decipher. You can only get that through being very mindful of what's going on in your body and what you're feeling. Flight, so another sympathetic response, that's when you're fleeing. An example of this is I had a guy in group who basically one of his biggest triggers is that he would be dismissed, no one would hear him. And when he was prompted to share more, the response really was to run. So he got up, he left, and approached me later and basically said, "I just don't know what happened there." And we had to process what happened, what could have been impacting, like who we were to him in that room, and what the trigger was. So it's a really common one. Flight is actually probably the most common one. Obviously, if we can get out of a situation, we're going to do that first. We're not going to choose the other ones typically. So that's a common one. Freeze. So freeze and faint. I'm going to speak to this a bit. These often get confused. The faint and flop. I personally don't like flop. I like to say faint. But they often get confused because they're similar processes. I like to think of freeze as a sympathetic, so a very hyper aroused response when you're shutting down. That typically doesn't make a whole lot of sense, because if we're shutting down, we're maybe going into the parasympathetic branch of the nervous system, which is to shut down. But when you look at the literature on a freeze response, the heart rate is actually quite high, where that wouldn't be happening if we were in a parasympathetic state. It would actually be quite low. So what I like to think of freeze as is, let's say you are in an argument with somebody and you feel like you can't talk or get your needs met, or express them or feel heard. Somebody might just shut down, clench their fists, and almost feel bound, like they can't say anything. They're still elevated, but they're frozen. Something is telling them don't engage, and also don't run, either of which aren't exactly safe. So it's just a shutdown, a frozenness. Dissociating can happen here too, where you actually someone leaves a situation, they're in a different place, just basically waiting until the situation context abuse is over. Fawn, this is more of a social stress response. So this is one I typically see a lot in really highly dysfunctional families, where the children don't exactly get to express autonomy or get their needs met. So I have to then adapt to what's in front of me. I have to adapt to my environment to keep me safe. I have a client who was subjected to almost daily beatings by his brothers. And he really had to learn what to say and how to say it, and manipulate the situation to avoid beatings. I mean, central to fawn is manipulation. And I think manipulation gets a really bad rap sometimes. It is a safety-seeking behavior for our clients, and we're often taught to almost look at that in a negative light, when really we need to be approaching it as what did this do for you? Like anything else, addiction, behavioral issues, how is this keeping you safe, and then processing that with them. And then faint and flop, this is a parasympathetic, so hypo response. This is basically just surrender, like total disengagement, fainting at the extreme. I would say basically totally shutting down. So you could see there's actually a documentary, I can't remember the name of it right now, I'm sorry, on Netflix, that speaks to what they call resignation syndrome, which they're finding in a lot of not a lot of, but some kids who are fleeing violence in their home country, and basically their whole body just shuts down. They're still alive, they just completely shut down. There's so much fear of possibly returning home. That's the extreme parasympathetic response, a total shutdown. So I like to provide all 5 of these. Typically you might hear fight, flight, or freeze, but I think fawn and differentiating freeze and faint is really important, and might help you see things in a bit of a broader perspective if you see it come into your office. So those are the typical stress responses we see. So dysregulation, to kind of marry the two here, when there is, like I was saying previously, when the stress in the environment is not moderate and it's extreme, we're going to go into a stress response to keep us safe. So that's how that works. So I like to comment on the role of attachment. So So this is obviously borrowed from Sue Johnson, her work on attachment. She's fantastic, fantastic work on attachment. If anyone has a chance to read her books, I highly recommend it. It's highly related to trauma as well. We need to basically, what I wanted to touch on in this is when a child's cortex isn't developed and they can't really regulate themselves, we need a regulator. We need someone attuned, responsive, and engaged with us. The really backwards part that I see in our clients is oftentimes they had to be the caregiver for their caregiver at an age in which that should never have happened. They learn what masks to wear or who they need to be to get their needs met. This can cause all sorts of trouble. You can think of a kid who can't regulate or can't make sense of their world yet. Being left alone with that is highly problematic. We see a lot of negative thoughts, negative core beliefs that really drive behavior. And since somebody's not helping them make sense of situations and in their environment, all of this stuff hangs out in that very primitive area of the brain, and we actually don't, there's no awareness around it. So it might seem like a very random occurrence if someone's triggered, but it might be something from childhood that hasn't really been looked at yet. Actually, I'm going to get into this on the next slide here. So this is where I'm going to look at implicit memories, activation, procedural learning. So like I say, when there's stuff floating around in that primitive area of the brain, that could be anything. Often I see this in facial expressions. They can be smells. It can be anything. And what happens is it triggers an implicit memory, which again is hanging out in that area of the brain where we don't really have awareness around it. So we haven't been able to assign it into a narrative. We haven't made sense of it yet. It's not come to our conscious awareness. So the body responds to it. This is why we work with the body sensations so much is, when something happened, when you got triggered, what just happened in your body. And then you can do all sorts of things therapeutically with that. This is where you can work in that. So like, work in internal family systems, what part is that coming out, doing EMDR, just inquiry as to maybe where have you felt that before. But in terms of this stream, it starts with the trigger, an implicit memory is activated. So let's say one I often use in this is I work with a lot of men who have really had to be caregivers for their mom or their dad. So neediness can be a trigger, feeling like somebody needs something from you. That can have an implicit memory attached of, mom being dysregulated. I need to fix her, and which goes into a stress response. So their nervous system activation, stress response. So maybe this person typically fawns. So what do I need to do to get mom to shift? How do I fix her? Who do I need to be for her today? And that's the procedural learning. All that happens in a nanosecond. So that's often when we're triggered, we'll go into a behavior that's kept us safe. So when we get a lot of caretakers in treatment, we help them understand like where this has come from, how they've been kind of wired to do this, how their stress response, nervous system activation, and implicit memories are all playing into this. And really helping them understand that this is a role that was assigned to you. It maybe wasn't one that you chose, and at least giving them the choice. There's nothing wrong with helping people, but if it's at the expense of yourself and you're so burnt out that you're landing in treatment for help, that's when we need to balance it out a bit. So this is an important stream to understand. Trigger, implicit memory. That's going to obviously trigger all that stuff in the primitive areas of the brain, nervous system activation, and then who do I need to be safe? So this is where we'll get into strategies to help with dysregulation and stress responses. So when I look at the neurosequential model, that upside down triangle there, we need to follow it first. So oftentimes people try to talk people down, or they'll try to talk themselves down, or they're going to try to think about something first, but that's backwards. So if you're triggered and you're in a stress response, you need to regulate first. So you need to regulate. So let's say somebody's quite anxious, fearful, maybe there's rage or anger, they're going to need to downregulate into that window of tolerance. Then once they're regulated, they need to relate to others. After that, when they can relate to others, they feel supported, their nervous system is balanced and regulated, then they can reason. They have all those wonderful areas of the brain available to make sense of what's just happened, and get help from others to maybe get feedback or understand what's just happened. So it's really important to follow that stream upwards rather than down. So this is, so basically this is various strategies. Oh, there's tons more, but one of the things that's really important is to teach those emotional regulation skills. So these are your DBT skills: meditation, mindful walking, breathing, among hundreds of other regulating activities. Doesn't have to be your typical breathing meditation. There's tons of other ways people can regulate. And that's going to look different for each person, and that's okay. It's just really about what works to bring yourself down or up to regulate yourself. So by extension, we also need to be teaching a daily, or incorporating those skills into a daily grounding practice. We need to get the body and the mind used to being regulated. So again, there can be secondary gains of being in arousal state. So you think of somebody coming into treatment who is worked as a police officer, was in the military. They're going to, hypervigilance is actually quite safe for them because they're not vulnerable. They're not going to miss anything. So if I'm always on guard, I'm not, I'm safe. I'm not in danger. My family's protected, when really there's no danger around. So we need to get them used to being calm. And when I say that to guys, sometimes we need to get you used to being calm, and they're going, oh my gosh, I don't know if I can do that, right? So it's also important to compassionately inquire about, are there any secondary gains with staying dysregulated? And there usually are, and that's okay. We just need to talk about them and maybe provide some psychoeducation as to why it's really important. But again, that very compassionate approach where we're not, telling them you need to do this, you need to do that, but really just, okay, that makes sense for what you were doing. Of course, you would maybe be hypervigilant a lot of the times. So mindful awareness of emotions and body sensations. So we are at Edgewood. I don't know about other programs, but I know for what we do, we're very focused on mindful awareness of what's going on in your body and what your emotions are. So we follow the neuroscience around. We need to understand that what's happening in that primitive area of the brain, dig it up, take a look at it, and create conscious awareness around it. If you're mindful and you can tell what's going on in your body given a certain context, you're better able to match it to, is this happening in my reality right now, or is this old stuff coming up for me? And that in itself, that curiosity is so important when we're looking at reorganizing stress responses and dealing with dysregulation and trauma. By extension, identifying triggers, really important. Like I say, sometimes those triggers might not be available to people. It could be implicit memories happening. Dr. Perry, in one of his books, talks about a kid who basically got dysregulated because of the smell of a deodorant one of the teachers was wearing, which was very similar to his abusive father. I mean, that nobody had a clue until they just kind of got curious and played around with it. So there's going to be stuff that the triggers that are difficult to identify, but it's always helpful to try to identify them. So understanding procedural learning. So again, what kind of behaviors are people engaging in that have kept them safe? So when someone's been dysregulated and in a constant state of a stress response, how are they behaving? How did that keep them safe? Why? Unpacking them, helping them align to their values, who they want to be. A lot of times this old stuff coming up is actually pulling them back into a place that they are trying to get out of. But the emotional pull is so significant because it's kept them safe for so long. That confrontation between where I want to go and where this is pulling me back to can really be helpful to really understand in terms of a broader perspective. So that's highly important. And so cognitive restructuring, behavioral modification. So basically with this, there's a couple of things we've got to look at. It's wonderful to understand why things are happening and see where things come from, look at the root, but we also have to restructure how people are talking to themselves and how people are behaving. So we got to look at how people think about, so their core beliefs, what is it? It's usually rooted in a trauma. And then what kind of thoughts do they have about themselves based on this core belief? We have to work to restructure that from that CBT model. And also, even though we know where things are coming from and we know the why and we know the root, we still need to change behavior. So we can't go back to doing the same things we've been doing because that's going to just repeat this avoidance cycle. So I feel something that's negative and I escape it. So we look at moving towards that and understanding it, being mindful, and then by extension, co-regulating, which is the next one. This is arguably, for me, my opinion, is one of the most important treatments for trauma, dysregulation, and being in a stress response. I often tell my clients here, we can do, sessions every day, we can do group, but really where you're going to find a lot of the magic here is within your peers and regulating with them. It's so important. A major finding in the literature is someone's relational health is actually the best predictor of mental health compared to someone's history of adversity. This is why the ACE scores can be a little bit problematic. What research has shown in long-term studies is even somebody who scores a 5, so adverse childhood experiences, with good relational health, so they have five significant adverse experiences in childhood, can actually do much better compared to somebody who only scored a 1. The difference being the one with the 5 has is a community, has supportive people to help, and has very good relational health, feels supported, that kind of secure attachment I was speaking about with that R model. So that secure attachment that I know somebody's going to be there for me, that's really important. So and the biggest protective factor, and I would argue, to experiencing trauma and healing from it. Sometimes though, narrative exposure treatments are necessary. So this is where we're going to be doing our EMDRs, ART, narrative exposure. So again, telling somebody's story, looking at the story, looking at it in succession, creating awareness, having that linear autobiographical narrative that we're speaking of to make sense of all those fragmented parts. Sometimes that's necessary to desensitize what's going on. The other thing just generally is creating a safe, positive space. Typically I know a lot of people want to move fast with, let's hit the ground running, but we also have to understand people who have been highly traumatized. Sometimes it takes at least 10 to 20 sessions for a client to feel safe with us. That's what the research shows. And we also have to understand that if you're a therapist, that therapists themselves are triggers. And not to take that on and take it personally, but just understand the client's experience. I've unfortunately had a few clients who have been, molested or sexually abused by therapists or support workers in the past. And I have to understand that that's going on in the room. And I have to take it quite slow with that client. So that's another thing to be mindful of. Even the process of asking for help can be triggering. So really what we're doing is we're building, Dr. Perry uses this metaphor of building new roads. So when we are in a, that stream of trigger, implicit memory, activation, and then behavioral response, so procedural learning, that's a one-track road. But what we're doing when we're digging up these experiences and we're looking at them and we're mindfully aware of everything and we're going into treatment, we're building exit ramps onto new roads. So that old road, the one that's bumpy and gravel and it's got potholes, the old one that's not really working so well, that's staying there. It's not going anywhere. But we're providing options. So you can go take this nice 4-lane highway over here. That's an option for you. And just know that, triggers are going to happen. You might land in the same place, but it's about the confidence to get yourself out. That's why grounding and regulation is so important. I usually say to my clients, have 3 to 5 grounding skills that you're very, very confident in, that are going to work for you to either up or down regulate. And then finally, why is this important? So, first of all, physical health. That when people are in prolonged sensitized stress responses and continually dysregulated, they got so much cortisol pumping through their body. We know that cortisol highly affects immune function and inflammation, among others. And as research continues to come out, I'm quite confident that it's going to be involved in a lot of other health issues as well. We're a very stressed culture. And I think it's just going to continue to pour out more research on really the negative effects of increased cortisol over a long period of time. Mental health, so emotional health. This is a significant one too. A lot of times anxiety and depression, as you can see, mirrors a stress response: hypoarousal, depressed, hyperarousal, anxious. Often people we're getting in our trauma program have been labeled with generalized anxiety disorder or major depression, and that's not quite what it is. Yes, they are presenting that way, and it would be easy to understand why someone would give that diagnosis, but it is also about that nervous system being out of balance, and working with that. And spiritual health, really trauma disconnects us from any sort of spiritual health. What makes us, what brings us joy and passion in life and meaning, and we're basically, people are surviving, not thriving, right? So it detaches us from any sort of spiritual health, whatever that is for the person. And connection to self and others. Like, people are very disconnected from themselves. They think of themselves in a very shame-based way. They're completely disconnected from community. We've seen how important that is. And when somebody's aligned with their values and understands where they want to go, they have hope. Hope is such a central ingredient to any sort of change process. So for me, those are a lot of the main reasons why it matters. The other last point I'll say is this takes time. It takes repetition. I'll get people coming into a 9-week program, and at the end they're struggling with something that just came up and there's shame around it. And I just said, look, you spent, look, man, you just spent 40 years in this cycle. How do you want to get out of it in 9 weeks? Like, it's going to take time. It's going to take repetition. That's okay. Having compassion for yourself and for the client, that this stuff's going to repeat. It's about, getting back on that other highway. So that's something I like to express as well. Repetition and time are extremely important. a lot of mindfulness. And I think that's, well, looks like I've got about 10 minutes for questions. So that's all I got for you.
Thank you so much, Ryan. That was great. Very informative as always. That's why we keep bringing you back.
Thank you.
Oh, lots of interest with questions for sure.
Sure.
We can start off just kind of off the hop since we're talking about grounding practices most recently. Can you please provide some grounding practices, like examples of them?
Yeah, so again, there's so many, like, so again, to ground, I'm gonna want to incorporate the senses. So whatever that is for somebody, we use, as, for example, you could use essential oils. Remember, with smell, the olfactory bulbs are very close to the limbic system. And let's say someone has fond memories of baking sugar cookies or something. You're going to maybe bake sugar cookies. That can be a grounding practice. What I'm trying to say is you can get very creative with it. But the common ones are like boxed breathing, to bring somebody down whenever there's very deep breaths. You're directly tapping into the parasympathetic branch, telling your system that it's time to rest. It's okay to shift from that hyper-aroused state to a lower state. It's okay to slow down. Breathing is to be honest, is probably the most effective method for me. Like breathing is so important. Always have your breath. There's other techniques through tapping, through eye movements. Walking is extremely good. Slow pace, mindful walking is rhythmic. Rhythm is highly important, because rhythm goes right back to the womb. The baby is regulated by the mother's heartbeat, which is rhythmic. And so rhythm is very important. Dance, music, and walking, all these sorts of things. But the list is too long to go into all of them, but I would say bringing it back to the breath is so highly important.
Perfect. Thank you. So does the fawning stress response develop into anger, resentment later on? I see this response in some children and wonder if it will have negative consequences.
Yes. It's a complex response and it can present various ways, but that is something I do see. How it presented clinically, actually, funny enough for me, before I did this webinar, was in a session with a client who he basically was caregiver for mom, and he had to he at the expense of his autonomy and his own needs. So he learned that whenever someone's dysregulated, he has to basically fawn and fix and be the support. Now, fast forward, and he's grown up with kids and married. He feels like he doesn't have autonomy and can't get his needs met. However, he doesn't exactly express those needs very well. So he holds on to it, doesn't communicate properly, and then it boils into resentment and anger, because there's an aversion due to the fear of being dismissed. And so he just holds on to it. He doesn't express himself. So then it does go into that resentment and anger. And that's what I'm trying to help him with. It's a good question. Yeah.
Yeah, topical for sure, considering. Okay. So where can we learn more about the fawning response?
Fawning response. Good question. We have a lot of it in the program, so we don't, I can definitely fish out some resources, but it's just such a huge part of our program. I haven't exactly looked at, I guess, it's just something we know, I guess, is one of those things. So any sort of literature from, I'm just trying to think of some books. The betrayal bond is quite good for that. It's all about kind of adapting to a dysfunctional relationship based in fear. I don't think he outright says it's fawning, but it's very much speaks to that. Anything by Dr. Perry, and I think so. Really, actually, that book you did with Oprah is quite good. What Happened to You? It speaks to a lot of this stuff. So I would recommend picking that up too. That's a really good digestible read that he's not getting too much into neuroscience where it gets unreadable. But it's really informative. So I'd recommend that one and probably Betrayal Bond.
Awesome. Yeah, I'm literally writing everything down to make sure that it's included as resources. So we'll be good. Appreciate that. Thank you. So are peer support groups a positive contributor to relational health?
Yeah, absolutely. I would say we have to make sure that those are positive spaces for our clients. But if it is a positive space and it's supportive and it's like very congruent with what we're trying to do, it's invaluable. It's invaluable. It's, to me, one of the most important part of a therapeutic process.
Absolutely. There are a couple questions about our programming specifics. So are your programs only offered in person or also virtual? At EHN Canada, we have a variety of programming with hybrid models as well. So for more information, you can check out ehncanada.com. And there are some specific questions about referrals too. So we can, I can provide some emails as well, but I'll post this in the chat. You can follow up for sure through referrals@ehncanada.com, and you can discuss anything in terms of programming, next steps, whatever you need, and then they'll put you in touch with the likes of Ryan. But that will be for sure, like the next step to take will be to contact this email, which I will post in the chat, and I'll include it as a follow-up resource, of course. And now just to get to questions. Can you provide some reading suggestions in the follow-up email? So do we want to talk about, they want to go more so like into theory and clinical tools. So would there be any other recommendations that you could have, or we can talk about this offline too, if you want to compile a list, but there's a little bit more for clinical specific that they're looking for.
Yeah, just off the top of my head, like I say, that book, What Happened to You, is really good for theory around this stuff. You're gonna see a lot of what I just spoke about in that book. He really takes it all of, so you can go to even Dr. Perry's website and even type in neurosequential model to Google, and it's gonna take you to his website, and there's tons of resources on there, tons of learning, research. And if you're looking for more of all of that amalgamated into a nice, gentle read, I would pick up What Happened to You. Great book. Other sort of books. So I'm just looking at my bookshelf here. Waking the Tiger, Peter Levine, great. Even like some of Gabor Mate's work is great. He does a lot of good YouTube videos. The Body Keeps the Score is great. That's a classic. And let me just see here. I think those three would be a good starting point. But it typically depends on topic, because Waking the Tiger and The Body Keeps the Score and that book I was telling you by Dr. Perry are great for theory and practice. But then what you'll notice with books is they'll funnel down into very specific areas. And if there's any questions about specific, clinical presentations that you want to address, just shoot us an email and I can compile a list for you.
Awesome. Yeah, that's great. I have a good feeling there's going to be a lot of resources to follow up. So this is great. Okay, so there is a question speaking to first responders. So can you speak on cognitive resilience for firefighters, police, paramedics, first responders, and those subgroups using grounding techniques on the job for self or citizens? And can this be a separate session for audiences focusing on the likes within this category?
Yeah, so something that I think has been started to be implemented is the debriefing groups. Super important. That typically I don't know for sure. Obviously, I'm not in any of these systems, but debriefing after an event, having mental health resources available right away, and having peer support right away, and just talking about it without going for a beer after, because that's a lot. Hey, let's go for a couple beers and talk about it. Typically not great. Then the brain is associating drinking with regulating after a really stressful experience. So I'd say mental health support, grounding skills. So teaching grounding skills to all of the first responders, extremely important. Teaching them this type of thing as to why this is important, also really good. So I'd say peer support, psychoed, grounding skills, and access to mental health resources that would be my preferred gold standard. I don't know how realistic that is, but if I had to choose, that's what it would be.
Perfect. Thank you so much. So it looks like we have time for one more question. So could you please give an example of a secondary gains for being dysregulated?
Yeah. So so I really, the one I always come back to is the hypervigilance. So I see this a lot of people in treatment. I have a lot of guys that want to activate themselves into hyperarousal. I'll often tell somebody who's getting angry at little things all the time, you're wanting to get dysregulated. You're wanting to achieve that safety you experience in hyperarousal because you're hypervigilant. You're constantly scanning and assessing for danger. So that's going to make the person feel safe who has been confronted with prolonged exposure to danger. So I'm thinking of a lot of our military vets who have been overseas, a lot of kids who grew up in abusive, explosive households where they didn't really know when their parent was going to rage out. They're constantly hypervigilant, scanning for threats, whether that's in an environment or relationally. So hypervigilance itself can be safe in that sense, and that would be the secondary gain.
Great, thank you so much for that example. Just to kind of close things out, I'm gonna literally just read one of the chat boxes, and it says, Ryan's presentations are always fantastic. You never disappoint, so thank you so much. And to reiterate that, literally the words out of my mouth. So Ryan, thank you so much again for taking time today to talk about this important topic, providing ample resources and information for people to follow up about. And we're excited to have you again, because I'm for sure going to follow up for another session. So I appreciate it, Ryan. Thank you.
Well, I always love doing these. So thank you for having me. I'm really passionate about the topic, and thanks everyone for listening. I'll see you soon.
Yeah, and thank you so much for everyone attending. We will be following up with an email sometime mid to late next week that will include a copy of today's slides, additional resources as mentioned, a copy of the presentation as a whole, as well as your CEU certificate. Again, if you attended by phone, please email me at jhouston, spelled like Houston, @bellwood.ca, and we can go from there. Thank you so much and hope to see you again. Take care.
Thanks, everyone.